Shah and Dr. Sunil Bhatt for moderating the session, and thank you for having organized this wonderful CME in a virtual manner for all of us. So I'll be talking about the conditioning regimens in the malignant allogenic stem cell transplant. The outline of my talk for the next 15 minutes or so will be the evolution of conditioning for stem cell transplants. How did it evolve? What is the current focus on improving the conditioning regimens that are already available in terms of minimizing the toxicity and preventing the relapse at the same time? And then one of the drugs that I'll be discussing about with the focus on treosulfan, its pharmacology and the research data that is available. So the science of transplant probably evolved with the use of radiation-based therapies in guinea pigs and mice, and that was the time when probably it was used, and it was found that the guinea pigs and mice, the hematopoietic system for those did not recover, and that could induce a lethal injury, and at the same time it could kill all the diseased cells in those particular organisms. This concept was harnessed first by Professor Don Thomas. That's not an unheard of name to any of the transplant physicians. Way back in 1957, when he infused a bone marrow in a patient of aplastic anemia who was on the verge of death, and for a patient of acute myeloid leukemia who was on the verge of death because of progressive disease, and ultimately the patient died, but he tried at least infusing these type of concepts for these particular patients. Almost 20 years later, he published a data of 100 patients with acute leukemia who had been treated with chemotherapy, TBI, and allogenic stem cell transplant. What he had done, he had divided these patients who were treated into 4 groups based on the escalating intensity of the regimen that he used into various groups, and one of those groups also received TBI. What he concluded was there was no much difference in either of the groups based on the intensity of regimen that was used, most likely because of the reason that when the intensity was lower, the relapse was, when the intensity was high, the toxicity was the problem. So the efforts paid off. He received the Nobel Prize in 1990 for with Professor Joseph More from the same center. That era probably followed both the regimen in various permutations and combinations, evolving with the focus only on the improvement. Because we still know that we have been able to mitigate the risk and at the same time mitigate the toxicity of the regimens and transplant. So in this concept, the concept initially that has been followed for a bit of time, for a bit of decades, is that as we increase the intensity of the regimen, probably the relapse rates will go down. It's also known that beyond a certain point, if we increase the intensity, does not have any benefit because the toxicity overwhelms the chances of survival. So that what's linked to the various categories of conditioning regimens, starting reducing the dose from myeloablation to reduce intensity, non-myeloablative regimens. That happened because of the origin of this, because of the advance of and of the pseudonym-based conditional regimens. So that's what the is that we have a host of molecules that use this conditioning regimen that include non-myeloablative regimens, and we at the same time increase the immunosuppressive, and then we go to the purely myeloablative conditioning regimens. So the ultimate goal for all of us ultimately remains is the that has to be achieved to improve the overall survival is to reduce the relapse as well as the regimen related toxicity, the transplant related mortality, and that can be only we have some newer horizons available. So the conditioning regimen for a transplant patient would be one that ensures a consistent engraftment. It maximizes disease elimination, while at the same time we can achieve minimal toxicity. As of today, we probably have drugs or regimens that probably address these issues separately, but we need to identify a common platform where these issues can be addressed at the same time. So over the last 20 years or 15 years or so, what been evolved, worked upon in these directions. One of the most important drugs, the breakthrough from Fred H. was fludarabine, improvement in engraftment rate, prevention of the relapse rates. There were subsequently the drugs that were identified, the alkylating agents, the thiotepa and treosulfan. Also focused going on the use of to go do away with TBI based regimens and switch to total lymphoid irradiation. proliferation of various monoclonal antibodies, CD52, CD20, and polyclonal ATG has been utilized to with the same intent that if we can somehow give away with reducing the intensity and more of immune suppression, that can somehow be able to control the. So conjugates probably I'm not very sure if anyone is using these, but wherever it's being used, it's still a research phase. So coming to the drug of focus today, out of the box that we discussed, treosulfan, it has got a lot of zeros that we can see here, but it's a clear winner in the terms of reducing the toxicity in transplant setting, as we will be discussing in the subsequent slides. So that's the structure of treosulfan with the two hydroxyl groups, and that these are the two hydroxyl groups that distinguish it from its parent busulfan drug. So the milestones that treosulfan achieved was it was discovered way back in 61, but it was first used in breast, then it was approved for use in ovarian cancer in solid tumors, and gradually moved ahead in finding its place in transplant as conditioning regimen. So how does this treosulfan act, and how does it differ from busulfanate's mechanism of action? So this treosulfan has got two active moieties. It's a prodrug of these two active moieties, epoxide and diepoxide, that are converted to and these active moieties do the work for treosulfan in terms of the alkylating agent mechanism of action by alkylation, cross-linking. What's the structural difference of the two hydroxyl groups? The good thing about the treosulfan is that it's not water insoluble like busulfan and other alkylating agents. It's a water soluble molecule. Mechanism of action wise, the other thing like some of the studies, some of the early data on when it was compared to busulfan showed that treosulfan works more and typically more on primitive and committed cells, both while busulfan is more on primitive stem cells. Is because of those thrombocytopenia with busulfan. So, in terms of comparison of immunosuppression and toxicity, so immunosuppression has been based on some of the mice studies initially done, and they showed that the T cell suppression that was induced by treosulfan was almost 3 times, 4 times more than busulfan. So it has got a potent immunosuppressive activity as compared to busulfan. In terms of toxicity, we all have seen through years of experience that busulfan is liver, lung, bladder, and CNS. So these are the known side effects of use as conditional regimen, and we have all faced the toxicities of this drug. But treosulfan has supposedly shown that probably because of its the volume of distribution, its limit to the distribution to kidneys, it's probably not affecting the amount of significant toxicities in terms of VOD, pneumonitis, hemorrhagic cystitis, and convulsion are minimal as compared to treosulfan. Although the mucositis is mucositis, we have seen cardiotoxicity also, bone marrow suppression. All these are common features when we see in the. So, we've seen that there are some distinguishing features between busulfan, although the same group. Features some distinguishing features. So that's the reason why probably 2000 the trials that had incorporated whenever they used to incorporate any alkylating agent, treosulfan across all age groups, across all stem cell types, treosulfan as conditioning regimen. This was probably one of the first papers that combined treosulfan with fludarabine with at 30 per meter square into 3, and they combined it with fludarabine, and that showed that the toxicity, the extramedullary toxicity, was mild, grade 3, very minimal grade 3 toxicity with a good long-term 2-year survival rate of almost 75%. So that probably paved the way for further trials going beyond this point. So then happened the dose finding studies for finding the optimal dose for treosulfan that were considered for upgradation were first from 10 to even 14. These were across across Germany, and that was a multi-center trial that they conducted. And what they found was, in terms of progression-free survival, there was no much difference. 5 years survival between 10 grams, 12 grams, and 41 grams was not statistically different. It was between 41 and 45%. But when it came to relapses, relapses showed that the relapse rate was significantly lower in the 14 grams group. 5 years versus 40% relapses in the 10 grams. So that gave us further studies that 14 grams per meter square probably became clear when we were with sugar. We know that, when we are using other ablative things like maybe with the IoT, maybe 10 grams is sufficient. But when it's used with sugar, then maybe 14 grams is a good. So then obviously the comparison, the only comparator which probably treosulfan intends to replace is busulfan. That was the study, the EBMT working, leukemia working party, in a retrospective manner across its EBMT centers. And what they found was, they compared the flu 4 versus flu 2 versus flu trio 12 and 14. So in these groups we can see there were total, like most of the people you can see from this number of patients that were enrolled, would not be using the IoT. We limited the number of patients with IoT. So if you see the patient characteristics across the group, the FuBu4 had a significantly better patient. The median age was lower. The patients were early CR1 as compared to the groups that they were in the higher C2 and C2 group. So the patient profile for the FuBu4 was probably better than the treosulfan group. So in the left two columns, if you see, mortality was significantly improved. If the left two columns are for all the patients taken together, the right two columns indicate the patients with when they had progressed to transplant, they were not in remission at the time of transplant. So in the left two groups, if you see, it's all leukemia-free survival, overall survival for all patients with acute myeloid leukemia across the four groups was statistically not different when we take the total number of 3,000 patients as one group. But since in a multivariate analysis they identified the disease status at transplant was the most, and analyze the data, those patients were not in remission at the time of patients, especially the FT4, FT14, showed a better leukemia-free survival, and that was the leukemia-free survival and both the overall survival also. So, these were patients who are aggressive. Patients, the future is a good regimen as compared to either 2 days or 4 days. That followed a host of other studies across studies from pediatric and adult patients who undergo high risk hematologic malignancy. They found that busulfan is a robust and rapid minimal toxicity. The toxicity encountered, there were practically no grade 4 toxicity. One patient had a mucosal toxicity and limited grade 4 toxicity. So that followed another study, elderly acute myeloid leukemia, and they showed the benefit of using this across the different groups. It has been tried in non-Hodgkin lymphoma also, that have shown that patients who followed by an allogenic transplant at relapse, they fare poorly as compared to those patients who progress to an transplant in cases of refractory non-Hodgkin lymphoma. So it has been tried and utilized in good benefit. So I'll not take much time now. So briefly, we at FMRI have started using treosulfan for our patients because of the main reason, because of the toxicities that we encountered during the busulfan period. And for the last 6 months or so, we have switched to treosulfan, more so specifically for mass sibling donor transplants and preferably also for haploid transplants, where so in patients with acute out of these 13 patients, as a group, 4 patients died.